Well, obviously, we need to work on that a little bit. Basically, the point for that, and we, again, didn't quite make the point. The point is, heart attacks and strokes are probably still killing more people than COVID-19, even in the height of the current wave of the epidemic. I'll work with Carl some, and we'll clean that up some to help make that point. The whole point was to compare the projected heart attack and stroke cases to the documented COVID cases. And as many of us know, in terms of watching this, that the underlying one of the major underlying pandemic issues is impact on our immune system from prediabetes, especially the pandemic of undiagnosed prediabetes. COVID-19, one of the major risk factors is prediabetes. A lot of people are getting coronavirus infection, but not a lot of them are getting COVID-19, the serious illness associated with it. Having prediabetes is a major risk factor for not just having mild coronavirus infection, but for having very significant lethal COVID-19. Again, Carl, we need to work on that a little bit to make it a little bit clearer, but hopefully it's at least a reminder to help us get the point across. And thank you, Joe Riley, for suggesting it. And hopefully we'll get our act together in terms of making that point more clearly. The program today, and we're looking to get our programs a little bit shorter. The program today is who is immune to the coronavirus, and what does immunity actually mean? Now, most of us would tend to think, well, once you're infected with something, a person's going to be completely immune for life. That really only applies to certain infections, like measles, for example. Coronaviruses are, to use a quote, more complicated, end quote. So, Carl, you want to show the clip on that?
It's been widely assumed that if you've had coronavirus, your body will develop immunity. But the World Health Organization now says that may not be true.
There's been an expectation maybe that herd immunity may have been achieved and that the majority of people in society may already have developed antibodies. I think the general evidence is pointing against that.
For those who've had the virus, the temptation to purchase an antibody or serological testing kit is high. Antibodies are little bits of Y-shaped protein that help fight infections. When we get one, our immune system produces them to help us get over it. Once produced, the antibody attaches itself to the antigen of the virus and destroys it, helping us defeat the infection. Once the virus has been destroyed, the antibodies stay in your system for a time. This is what the blood test looks for. But for new viruses like COVID-19, doctors simply don't know how long these antibodies will last or if they're powerful enough to guard us from future infection.
We can use a lot of work of what we know about viruses like SARS in years gone by, whereby immunity peaked at two or 3 months and lasted for around 3 to 4 years. But of course, this scientific knowledge will continue to grow.
So you start to get a little bit better picture of what immunity might mean, or begin quote, immunity, end quote, might mean in terms of the coronavirus family. Many of us would say, well, we just don't know. We just don't know for SARS-CoV-2, the current coronavirus. But, you know, coronaviruses have been around for a long time. They've been part of seasonal cold and sometimes, not the influenza, but a seasonal cold, sore throat type of upper respiratory infection. And this is not the first time that we've looked at things like that. Also, there's been a little bit of information regarding the previous potential pandemic coronaviruses, SARS and MERS. So we're going to take a look at that specific data to see what do we know about the coronavirus meaning the family of coronaviruses. what do we know about immunity for those? And what do we know about current SARS-CoV-2 immunity? We know a little bit more than we might think. And again, we'll cover that in just a minute, but just 2 quick slides in terms of other videos that we've covered and upcoming topics. One of our upcoming topics is pregnant women and coronavirus. Again, we'll be covering an update on effective COVID-19 treatments. Previous topics include the 6 conditions for ending lockdown. And again, people like to beat up on WHO and CDC and other groups. There's too many groups and too much correlation in terms of conditions for ending shutdown. It's worth taking a look at what people are saying in that space. Unused coronavirus tests in US labs. If there's one continuing problem that's slowing us down and costing huge numbers of lives in terms of management of this pandemic, it's the failure to have tests available. And then once we finally got tests available, we weren't using them. So just a mess. We covered that a couple of days ago. Then the next question is, well, are we hitting the peak? And if so, which peak and how do we define a peak? Again, some previous information on previous programs. And multiple times we've covered ACE receptor blood pressure medicines. Again, those are all things that are available to review. Heart damage, COVID-19, and herd immunity. Last item before we get into the program for today. We've got a lot of people continuing to ask about, well, what is insulin resistance? How do I measure for that? Do you have systems for this? Can you help us? As we know, over 90% of people that have prediabetes don't know. We make assumptions about prediabetes. Most of those assumptions are based on if the person's obese. But you got somebody like me, I'm not obese, and I have significant prediabetes. There's a lot involving what we call epigenetics. My father was obese at the time I was conceived. My mother had some weight problems at the time that I was in utero, in the uterus. Both of those have significant risk factors for developing early prediabetes. And as I said, 90% of us don't know. You got to ask the question, why do so few people know that they have prediabetes? It's because our primary care docs don't understand that well on how to test for this either. The typical primary care doc looks at hemoglobin A1C and sometimes fasting blood glucose. Both of those are totally inadequate for finding these more subtle levels of this pandemic of prediabetes. So we're making some things available. We just had an email where a patient asked, do you have any options for getting the Freestyle Libre? And I'm trying not to touch my face and my head, but it made me want to put my head in my hands. That's what we do, folks. So obviously we're not getting the message out there as well as we'd like to. So that's all. Commercial break from our sponsor. Let's go back and talk about who is immune to the coronavirus and what does that mean? We'll do that right after Carl hits us with the water ball intro. So you may have seen a couple of these articles that were floating around talking about who is immune to the coronavirus and what does it mean? What do we know about it? You know, the reality is that most of our understanding of coronavirus immunity comes from SARS and MERS, not from those, but from seasonal coronaviruses. We have information, a little bit from SARS and MERS, a lot more from seasonal coronaviruses, and now, obviously, we're starting to get information about SARS-CoV-2. So let's talk about those for just a second. We've had information about the seasonal coronaviruses since, what, 30 years, 1977 and 1978. Small study did 18 volunteers. 18 volunteers were inoculated with a coronavirus strain. All of them developed colds. 6 were re-inoculated after 1 year. None was infected with the re-inoculation. The remaining 12 were exposed to a slightly different strain, and protection was only partial for that different strain. So again, it's not like we've got thousands of individuals in that sample, but again, you can start to get some of this picture that, yep, there does appear to be some crossover between at least those 2 strains, but what does that mean for SARS-CoV-2? Again, don't know quite yet. Study number 2 was in 1990. 15 volunteers at that point were inoculated, 10 were infected, 14 were re-inoculated with the same strain after 1 year. Less severe symptoms and fewer viruses than the initial inoculation. So again, you see a similar picture as what you saw before, and what you tend to see within families of viruses. You tend to see some crossover, but not complete. Another thing that you tend to see is with a lot of viruses, even with the exact same virus, a year later, incomplete, not 100% coverage, but significant improvement in immunity from being totally native or virgin to that specific infectious agent, that virus. So obviously there were no direct experiments done on SARS and MERS, but there's information that we have from them. For example, they detected antibodies in survivors, suggesting some protection for some time. 2 years for SARS and 3 years for MERS. Now, from these experiments, we can assume that COVID-19 survivors will have an immune response. The vast majority will. But what does the vast majority mean? Some will have better response than others, and protection may last in the medium term at least a year, although effectiveness might decline. One of the bigger questions that we covered in the antibody test was the discussion of sensitivity and specificity. I'm not going to get technical and talk about what drives those, but I will say this. In a very low prevalence disease, very low prevalence, meaning only 2% of us have it, which is going to be likely the case after the first wave of the coronavirus. Even with a relatively good test, a positive antibody test is as likely to be a false positive as a true positive. So you put that together with what we're talking about with programming today, and it makes you a little bit nervous about this whole idea of, oh, okay, so once I get a positive antibody test, I'm free, I'm good to go, and I'm safe, right? And I can't transmit it either. Again, it reminds you of that Dirty Harry quote, "Are you feeling lucky?" So these discussions, these thoughts, these concerns, these facts will become an important issue in terms of considering herd immunity, as well as considering return to work, return to society from our current lockdown. So some major issues and questions. COVID-19 reinfection, is that what's going on? Or was it just a false negative test, false positive test? Could have worked either way. So for example, you get a test, you think it's negative, actually it was the true test result, what it should have been positive, then you're not gonna, that's not so much of an issue with the reinfection. But think about the opposite. You get an antibody test, it's positive, you think it's a true positive, turns out not to be the case, and then you get an infection. Was that a reinfection? No, it was a previous false positive test. So, and again, you can start thinking of scenarios in this, and the logic can sort of turn your mind inside out. It's just something to be thinking about, something to be aware of as we go to the next phase of trying to get folks back out into the workforce. Only a minority will be immune to the SARS-CoV-2 virus, obviously. We are not ready as a society to take enough of infection rate to create herd immunity. For something as infectious as SARS-CoV-2, again, we've talked about it multiple times, maybe an R0 reproductive index of 3, maybe even just 2, but still a significant reproduction index. It's not going to be 2 or 4 or 10 or 20% previous infection giving us herd immunity. It's probably going to have to be 50% of us infected or more. So we're not going to be ready to wait till herd immunity. Mild illness might not always give immunity as well. You've seen that with other viruses, and there's some literature, some science out there that would indicate that's actually what's happening with SARS-CoV-2. For example, there were 175 Chinese patients in one study, 70% with strong antibody responses, 25% with a low antibody response, and 5% developed no response at all. So then again, you get back into that question, well, do these 25% with low response and the 5% with no response at all, how much of that is poor cross-reactivity to the test, perhaps a false negative test? How much of that was they did not create and retain significant immunity? Again, things we'll have to learn as we continue to learn more about this virus. Other problems, confounding is always a problem. It's a classic epidemiological issue. It's where the risk for the disease is also associated with the outcome. It gets a little bit technical. Again, the logic sort of twists your head inside out. Won't go there. Will infection with one coronavirus offer immunity against a related coronavirus? As you see with seasonal flu and other viruses, as they pass through huge populations of hundreds of millions of people, you get new variations. Viruses tend actually to mutate to a milder form because a milder parasite is more effective. It has more hosts that it can infect. So that's a potential good news situation for this as well as any other virus. But have we seen that yet? Again, I think it's way too early to tell. And what have we seen with mutated influenza viruses? Some cross-reactivity, again, just not very, very predictable at all. So will immunity to a coronavirus worsen infection to another strain rather than prevent it? And you've actually seen that with some of this. It's creating much more of an immune response, much more of an inflammatory response. And one of the things that we know gets back to that discussion about prediabetes, inflammation. The thing that's killing people in COVID-19, the serious form of the disease, is inflammatory reaction. So is it possible that in prior infection can make it more likely to have that high level inflammatory reaction? As you can see, we've got a lot of things to learn, and these are not insignificant items. Our lives depend on it. So I think, Carl, that covers our slide for today. I'm going to end the slideshow and see if we can put a bookend on that and start go in and respond to some questions. Teb Tingry, good morning. Dave Murphy, good morning, David. How are you? Bob Weiss, North Georgia Mountains. As we go along, do those who don't get COVID but may be minimally exposed to it possibly build any antibodies to it? you know, anything's possible. Here's the thing. I think if you develop enough of a response to it that you're starting to build antibodies, you probably had enough of buildup viremia virus in the blood to where you've got some sort of significant response. I mean, building antibodies itself is a significant response. And I showed this before with the antibody test and the PCR test. Typically with viral diseases, we develop what's called the IgM antibody at day 14 and an IgG antibody at day 21. It can vary, but those are some typical dates. Here's what also happens. Viremia, or percent of virus in the blood, tends to build up until you start getting that antibody. As soon as you start getting that antibody, the viremia decreases dramatically. Again, in most viruses. There are some viruses, classically HIV, where there are problems with actually decreasing viremia associated with the immune response. That's why it lasts for years. There appears to be some component of that with SARS-CoV-2, where it actually appears to hijack leukocytes, T cells, some of the immune cell family line. Bob Weiss, I work in a grocery environment. I hope you guys get official first responder status. My son also works in the grocery. He works at the meat department at Kroger. Dennis Williamson, good question, Bob Weiss. Greetings. Greg Clapton, it looks as though the VA data is evidence supporting the conservatism you supported regarding hydroxychloroquine and azithromycin. Yes, again, you know, I don't think there is a silver bullet for this problem. Thanks for pointing that out. Dennis Williamson, there's no sound yet. Good to go. Anonymous, hello. Possible people who are immune to HIV, of which there are some, they may be immune to the new coronavirus. Or there may be some people who are just inherently immune to the coronavirus, just like there have been some people who are inherently immune to HIV. Again, really, really good question. Shows what we call biological variability. Jan H, how can there be so few recovered with so many possible COVIDs? Or positive COVIDs, I'm not sure. Does the recovery take months? Well, that does appear to be part of the issue. It doesn't take days, like you see with measles and a lot of other viral vaccines. I mean, a lot of other virus infections. Does it take years and decades, like you see with HIV? No, it's clearly not. Doesn't appear to take that long. But we are seeing folks with, and somebody do a fact check on me for this one. I am pretty sure I've seen significant evidence for folks having some viremia, in other words, a positive PCR virus test for weeks after developing the antibody. Brian Smucker, are there other types of immunity besides the presence of antibodies? Well, yes. And I could go a long time about that because there's a lot of stuff. There's cellular immunity. There's humoral immunity. Cellular is the cells themselves. You know, when you talk about inflammation to artery walls, for example, that's much more of a cellular immunity process. Tends to take a little bit longer, has a different approach. If you look at TB, tuberculosis, that tends to be, and again, if my memory is correct, that's more of a cellular immunity process. On the other hand, then you have humoral or antibody immunity, which you see with a lot of viruses. And again, I think is going to end up being the major thing you see with this one. Luis Grados, any other coronavirus types that we can't produce antibodies to? I'm not sure. I'm not sure. There's a couple of assumptions here. I think what you're saying is you're assuming that from the data that we've seen so far that we can't produce antibodies to coronavirus. We can. The vast majority of us do. The real question is it going to be 70%, 95%, and how effective are those antibodies going to be? In terms of another way of looking at your question, Luis, is this: are there strains of coronavirus where we just cannot develop any antibody at all? And no, I think if that were the case, that would be very important information and very well known. Bert, I think that's Yamas or Lamas, Yamas. How about micronutrient education? Bert, I'm not sure if I understand, but if I understand your question correctly, you may be asking about micronutrients. That is things like vitamin C, zinc, quercetin. And again, we've had several videos on that. If you just Google Ford Brewer, YouTube, zinc, quercetin, coronavirus, COVID, vitamin C, supplements, you should find plenty of topics in that space. Teb Tingry, hopefully if immunity doesn't pan out, then we can use that to push for a major societal change in how we eat and how food is produced. Using this as a springboard to tackle metabolic syndrome and type 2 diabetes. Really good point, Teb. You know, Janice did a video with me called Silver Lining, COVID Silver Lining. And, you know, with anything as big as this, there's going to be some positive things that come out of it, despite all the death and destruction. And I do think there's going to be a lot of positive things. We talked about that before. I do think that you've got a good point. It's going to help people begin to realize long term, we can't continue to walk around way overweight. We can't continue to ignore pre-diabetes because it'll kill us. And as we've said multiple times, it's killing a lot more than COVID-19. Bert Yamas, no money in any nutrients. Sorry, next time. There's a lot of money in nutrients, Luis. The nutrients market has multiplied by a factor of what, 10? Just over the past less than a decade. The nutrients market is huge, and there's a ton of money there. Robert Simpson, hello. Well, just to your point, Luis, I think maybe you mean that you don't have big pharma money pushing things like vitamin C, zinc, quercetin, et cetera. And yes, you don't have big pharma money. I would agree 100%. I think maybe I missed your point earlier. Hello, Robert Simpson. Bert Yamas, Luis Grados, and not sure what that meant. Well, good luck finding studies. Again, we've covered several studies regarding zinc, quercetin, and vitamin C, and some other supplements, vitamin D3. Of course, there are no clinical trials about vitamin D3. There's actually some clinical trials about zinc, and again, we covered those. Herd immunity, are we talking about cattle? Not sure if you're being serious there. Herd immunity, in case you are, herd immunity is an epidemiologist's term. It means the more people that we have with previous infection in a large population, and in this case, we're talking about humans, but you can talk about cattle or any population. The more people you have that are immune, that therefore cannot transmit the virus into a smaller population, the closer you get to what's called herd immunity. Bambi Grage can no longer find the information on the CIMT tour. I'm signed up for Portland in July. Have they been canceled? Yes. They have been canceled for now, Bambi, and I'm sorry about that, but again, I think you understand why. Now, David's as eager to get out there and reopen these as you might be, as we are. Again, This is life-saving information, knowing whether or not you have plaque. And here's why. Bambi's asking about CIMT. CIMT, CT angiogram, and calcium score, coronary calcium score, are all much better ways of predicting heart attack than what we usually use. What do we usually use? Stress tests. Stress tests will only show potential risk if you have over 50% occlusion or blockage in your coronary arteries. 2/3 of heart attacks occur in people that have less than 50% occlusion or blockage. So by definition, stress tests are going to miss 2/3 of heart attacks. So and look that up, Google it. You'll see one of the Google snippets. You know, a snippet is position 0 on the SERP, the search engine results page. And they put it at the top, and you'll see it. If you Google, basically try something like false positives, false negatives, stress tests. And they'll show you, 1.5 million out of the 5 million done yearly are false. And we know that before we even do them. So again, gets back to one of my favorite quotes, are you feeling lucky? Yet, doctors feel like we don't have anything better for predicting heart attack and stroke. Doctors are not very aware of calcium score. They're not very aware of CIMT, and they're not very aware of CT angiogram. All of them have shown that they demonstrate the presence of plaque. And plaque is what causes the risk for heart attack and stroke, not so much plaque that you occlude the blood flow. Because it's not plaque occluding the blood flow, it is a clot. It's having inflamed plaque that releases in a liquid form out into the blood. When that happens, inflamed or liquid plaque releasing into the blood, it causes a clot. If the clot's big enough and it goes to the heart, it's a heart attack. If it's big enough and it goes to the brain, it's a stroke. If it's tiny, microscopic, a few hundred cells get knocked out, but you do that 24 hours a day, 7 days a week, for decades, and you can understand how you could get heart failure, dementia, several other things that we seem to think are just part of growing old, but they're not. They are preventable. So again, you got me started on a rant about unrecognized disease. Thank you for the question. Warren Crow, listening from my walk in the park. Well, thank you very much for joining us from your walk in the park. Bert Yamas, there are countless peer reviews. I'm not sure what you're talking about. Maybe on supplements, but I'm not sure. Hello, Joe Riley, Z50Z6. For COVID-19, you mean the immune... Lewis, just a clarification. The questions come in and they add up down at the bottom. I will usually hit a question. So you may be responding about what I'm saying right now, but I won't see that question again for another 5 minutes or so. So giving partial questions like that's basically just going to end up, I won't be able to give you a good answer or a good reply. Ted Tingry, have you seen any of the data from the WHO, CDC, et cetera, hacks? Don't know what you mean by hacks, Ted. I've seen a whole lot of stuff from the CDC and WHO there. Farouk Farr, good to hear from you, Farouk. Farouk is in the medical, I think Farouk's a doctor, a medical student in Iran, one of the hardest hit, earliest hit countries. And was one of the first, often responds and contributes and made us aware early on that young people were getting killed. I think he had a 23-year-old engineer, healthy engineer cousin or something that was killed with COVID-19. I'm leaving in a hot spot. Lost 25 pounds and taking turmeric, ginger, lemon, and vitamin D. And have been helping voluntarily part-time with a hospital on COVID-19 patients with basic protection. I'm fine. I'm very glad to hear that you're fine, and I'm sure your regional society appreciates what you're risking your life to help save others. I'm very impressed with that. Northwest Frontier, am I blocked? Jan H, thanks, Dr. Brewer. David Mines, Jason Fung, PrevMed, and Associates. I've become a convert. My missionary work with friends and family is struggling, trying to keep the faith. I understand. I tell you what, you know, it seems like just when you start getting some momentum on getting people to understand this subtle, the real killer pandemic, the thing that's disabling and killing more of us than anything, prediabetes, unrecognized prediabetes, then something like COVID comes through, SARS-CoV-2, and total distraction. It's totally shaken up our little group. As you know, we were focused mostly on that. And now we've had to totally reconfigure how we do videos, what we're making available, the content that we're covering, because people just got very interested in that. And what's frustrating, Jan, is this. As I've said a couple of times, COVID-19 and SARS-CoV-2 are they're very similar to heart attacks and strokes in that it's not just a heart attack that initiates out of the blue. It's not just a stroke that initiates out of the blue. It's not just COVID-19 that initiates out of the blue. It's all been, our immune systems have all been prepped with unrecognized prediabetes. And if we could just start getting recognition for that across, hopefully, as Teb mentioned earlier, we should be able to actually start getting some increased understanding of the importance of the prediabetes epidemic. Jerry West, we need to begin treatment with antivirals early when symptoms first appear. These drugs are not antibiotics. They don't kill the virus. They slow replication until the immune system can catch up. I agree on both points, Jerry. And when I just hit that, the comments get a little bit, when we get a lot of comments, they get a little bit of pent up tension, and you click, and then they just spring up, and it skips a whole lot of them. If I've skipped your comment, please be patient. Sorry about that. Northwest Frontier, as a teledoc, if I as a patient had to go into ICU, could you stop them giving me glucose and oil intravenously? There's a whole bunch of comments about that. I will tell you, once you go into the ICU for COVID-19, I think for the most part, the amount of glucose that you have in an IV is probably not creating significant immediate danger. The damage has already been done to your immune system. That's item number one. To be clearer, though, once you get inside the ICU, you're being managed by an ICU doc. They call them hospitalists or intensivists. Luis Grado, 70% is a minority. Again, Luis, I need to understand a little bit more about the context of the question when you write it down. Very admirable for best wishes. I agree. Brian Smucker, does it help to reduce the ultimate severity of the infection if you can slow the replication rate of the virus in the body? Theoretically, yes. Because, again, no matter how fast your replication's going, if it's going to take 14 days on a standard to create that first IgM and then 21 days for the IgG, you would think theoretically if you could get enough viremia to start that antibody development process, then the slower you develop viremia, the better. And that's where a lot of people talk about, well, that's why you should take vitamin D3, that's why you should take vitamin C, that's why you should take some of these other things. That's beefing up the immune system. Oh, the other one was BCG, the Bacille Gamete, Camille Gamete. It's a vaccine. It's a vaccine used in the third world for tuberculosis, and it appears to beef up the immune system. So there are a bunch of different ways of trying to beef up the immune system before you get to that development of the antibodies. In other words, try to slow down that increasing viremia or virus buildup in the blood. All of those are theoretical right now, because one of the problems with that assumption is that if you're slowing it down, you're still going to develop antibodies quickly. And I don't think we've got a lot of information around that. If somebody's aware of it, I'd like to hear about it. Jerry, for Oak Far, how a vaccine can be effective when virus is mutating all the time? Well, we did mention that, and actually, you see that with seasonal influenza. For decades, we've had monitoring and surveillance systems throughout the world for influenza. And by the way, the CDC in the US and other CDCs, like the Chinese CDC, are very much involved with this. WHO is involved with it. And parenthetically, a lot of that surveillance has concentrated around China and the East, because a lot of these, the seasonal flus have originated there. They've originated other places as well. But there have been episodes, and it's not unusual at all, to get the whole world, the Western Hemisphere, the world ready and geared up for a certain specific type of seasonal flu. And then only to find out that that one sort of dies out and another seasonal flu actually takes the lead, and we've built a whole bunch of vaccine for the wrong virus. So that happens. Now, are we going to get some cross-reactivity? If it's all within the coronavirus group, again, it's we talked about that earlier. Sometimes you might not. It's a luck issue more than anything else. Big Balla, hello, Dr. Brewer. If the government offers a vaccine for COVID-19, is it safe to get this vaccine? Well, as much grief as people like and blame as people like to put on the government and anybody else, authority figures, government, etc. Again, I work in this space. I've been crystal clear for the past few years that, like other people that do what I do with my background, that we were going to have a 100-year pandemic. And I was also crystal clear that we were not prepared for it. Folks like Michael Osterholm wrote books about it, which could not have been clearer. So we can blame the government. We can blame CDC for, I think they did make some very bad mistakes regarding development of the vaccine kit. We continue to have problems in terms of procurement, all of those things. Put all of that aside. Is the government going to recommend an unsafe vaccine? Some people have said that. And actually, I will tell you this. I am not a vaccine hater. I think vaccines have, I think people that, yes, we do get negative problems with vaccines. We've had problems with paralysis. I mean, serious problems with vaccines. However, what people don't understand is the death and destruction that happened to the human population before vaccines were developed. So any vaccine, just like any medical intervention, is going to have its strengths and its weaknesses and its dangers. Do I think the government is going to start recommending one that's dangerous? No, I don't think that. I think it's going to be a much more subtle question than that. Jan H. Jerry, rest, you're right on target. Drugs won't cure the terminally ill. Read as ventilated. Sad but true. Amazon. Have had 2 deliveries from Kroger and 1 from the Aldi's, both on time and delivery to the front porch. Thank you very much, Amazon. You may be responding. I was disappointed in our in what we did with Kroger. We did that a few weeks ago and didn't get what I wanted. A lot of the problem with what we didn't get from what we wanted was just the website itself. It wasn't clear. You could list things, but it wasn't clear that you're actually going to get them. And even if you did list them and you did say how many you want, it still didn't put those in your grocery box. So you ended up not getting a whole lot of what you thought you were going to get. And that had nothing to do with the mess that was inside. Again, I did a raft of complaints. I felt comfortable doing that. I used to work for Kroger. I was the corporate medical director in charge of the little clinic. So I'm glad that that worked, and I do have every expectation that they're gonna get to where they need to be. Andrea Harwick, when the studies are conducted, are the subjects permitted to circulate in society freely while they are infected? Well, no. In fact, it depends on which study you're doing. A lot of trials are set up in an area where people don't have access to anything else. That's because they want to make sure that people aren't getting exposure to anything else. You're talking about not exposure to the patient, but exposure of the patient's infectious process to something else. It's called human subjects review. They reviewed designs of these studies to make sure that we're actually being safe. So somebody donated $10. D. Crispin 1. Thank you so much. We appreciate that. And again, every little bit helps in terms of helping us get that message out there. Carlson Nielsen, immunity. And let me just say this. If you'd like to do that, Carl's got it up here. We can donate using PayPal. You can donate through Patreon. You can donate through YouTube Live. If you want to do that, the picture right next to it shows you how to do it. It's right next to the comment button or the chat button. Karsten Nielsen, immunity. Would really large amounts of black pepper, turmeric, cloves, aronia, etc., work to decrease the inflammation in the lungs and so decrease the fluid buildup? Don't think so, Carlson. Sorry. Which could better the patient's ability to absorb oxygen or even breathe better outside the respirator? No. Again, if you start looking at the supplements, I'm sort of unusual in terms of classically trained docs in terms of appreciating supplements. And it's because I've taken the time to go in and look. And I use a lot of supplements. But the assumption that the supplements that you just talked about are going to get you out of the ICU, I think is a big jump. Again, supplements can help given the appropriate way. And I'm also questioning how you're talking about giving it by, it looks like you're talking about inhaling them. No, you're not talking, I don't think you're talking about inhaling them. I will tell you this, I'm taking turmeric, I'm not taking cloves or black, well, I am taking some black pepper, cinnamon, obviously vitamin D, vitamin C, K2, several different things. You can find out, you can check in with our office. We have our supplements program set up a little bit better organized. It used to just be typical of me spewing a lot of science and data, but not so much well organized from a, so how can I get this done perspective. We've got a nurse named Lori. She's come on board a few months ago and has been learning the supplement space with us. And we've set up with a company. Now you can, if you're a patient or if you're not a patient, you're just interested, like to find out, you can check in with us, and we now have a supplement program based on whether you have type 2 diabetes, based on whether or not you have whether you're taking statins, for example, you should probably consider CoQ10. Now, along that line, should it be ubiquinol instead of CoQ10? I don't think the science really supports that. How about if vitamin D3? Most of us should reconsider our vitamin D3 intake. We were having this conversation, Janice and Michelle and I this morning. We're thinking about setting up a webinar specifically for supplements because, again, very, very big topic, big issue. And supplements didn't get there because they were pipe dreams and wishes. They got there because there was real data behind it. Kristen Nielsen, question mark. That doesn't help a whole lot, sorry. Give me a little bit, oh, wait a minute. So Kristen is saying, wait a minute. It's a 3-part with really large amounts of pepper. Okay. Who could better? Okay. And then a question. So Karsten, I'm sorry, not Kristen. Karsten, I hope that expanded response gave you a little perspective. Franklin Taylor, I officially, doctor diagnosed the second time, had chickenpox twice, 7 and 10 years of age, and shingles at 21 years of age. So I can understand about the not building enough antibodies concept. Well, you know, chickenpox is varicella, and very few of us totally kill it. That's where varicella zoster, herpes zoster, we don't really kill those groups, those zoster bugs. We dampen them down enough to where some of us, especially as we age and we start losing some components of our immune system, they start coming back out. Now, where do they come back out from? Those specific viruses, when we beat them down and get over the chickenpox, we get them out of every place except the nerve root ganglia. So you may have heard of things like facial zoster, where you get it's in a dermatome, a pattern where that nerve has that virus has crawled back out, that dermatome or nerve distribution. That's why you see zoster in a pattern, a stripe like that. Classically, you'll see it on the trunk. I'm having a senior moment. Somebody remind me of the name of Zostavax. There's again, another word finding problem, a vaccine for that. We used to have a Zostavax, which was a virus that was, it was what we call an attenuated virus, a virus that was still live, but it had been made not so bad, not so virulent. And since then, we've had a whole new type of antibody. Oh gosh, again, more word finding problems. Didn't sleep last night very well, so that's contributing some of this. More of the vaccine. Have another type of vaccine that's got a lot of what we call adjuvant in it. That adjuvant creates a bigger immune response, and because of that, people getting the new zoster vaccine really go through a lot of pain. Janice and I did a video on it. She really got beat up pretty badly with it, and it's almost like going through 2 or 3 days of the flu. Why do I digress? Why do I go into that? Because those of us that have had ocular zoster, in other words, that dermatome where that zoster came back and it involves the eye, some people have actually committed suicide because of the pain associated with it. The disability is devastating. So yes, we all wish that once we started developing an antibody to a certain virus, that was going to be the end of it. Not the case. It depends very much on the virus. With measles, yep, that tends to be the end of it. But as Franklin has pointed out, zoster is a different issue, varicella. Jackie Shaheen, every online website is back ordered for vitamin C, D, and zinc. Yes, it is. It is not pretty. Richard Lyon, how you doing? Oh, for the good old days when we could argue about keto versus vegan. Really good point. Tab Tengri, about 25,000 Chinese, CDC, Gates Foundation emails and passwords were leaked. Some have been using those passwords to go in and look at data. That's interesting. I had not heard that one. Karsten, overweight people need lots of oxygen for the heart just to function. And a big heart needs most oxygen, so overweight and prediabetes starves the heart, the patient of oxygen and foods. Karsten, you bring up a good point. If you may or may not have, those of you who've not seen our video on damage to the heart associated with SARS-CoV-2 or the coronavirus, COVID-19, you may want to go back and look at that, because there's been a lot of question about, does it directly damage the heart, or is that an indirect damage? Here's the bottom line. We know that once somebody gets in the ICU, they're having that kind of problem. Their heart rate's up 100, 120 from fever and inflammation and perhaps disseminated intravascular coagulation. We're making too many clots. And trying to fight all of that, the heart's under terrible stress. Well, if you already have blockage to your heart and can't get enough oxygen otherwise already, then going through this amped up phase where you go for days without the ability to rest, that damages the heart too. So some of the real question is, how much of COVID-19 damage to heart is coming from that lack of oxygen during the critical period of the infection, and how much of that's coming from the lack of oxygenation during that overstressed period? The reality is we don't know right now. So a very, very good point, Karsten. Thank you very much. To death of nutrient oxygen, death of the patient by lack of oxygen. Extreme or even overweight presses the lungs, so decreases their capacity. Often from COVID-19, it seems. Richard Lund, astragalus is one herb that increases natural killer cell levels. Richard's pretty well studied in this stuff. Thank you for your contribution, Richard. And Richard actually was helping me discuss our studio. He's a professional. He's on a professional studio staff. Has been for a while with the real studios, and again helped us a few times. BCG was mentioned in This Week in Virology, episode 604. Thanks, Richard. Will the herbal remedy of ivy protect the lung during infection? I don't know about that. In the future YouTube, would you check out and comment on Dr. Paul Mason's take on bad IV contents given to COVID hospital patients? Mason is a low-carb keto pundit from Australia. Thank you very much, Northwest Frontier. I hope to do that. There's a long list, though. And you're probably responding to my comment earlier about, I'm not so sure that, well, anyhow, that whether or not you have any dextrose or sugar in that IV is a big deal at that point. I'd be that's a very interesting question. D. Crispin 1, thank you again for the contribution, D. Crispin. Self-quarantine and healthy. We'll have to do this for a long time beyond the government imposed due to four comorbidity issues. Very daunting. Thank you so much for sharing that. And that's who this community is. We're the baby boomers. We're the folks that have risk for COVID-19 disease, death, and disability from SARS-CoV-2 and from heart attack, from stroke, and all of these. We talk about high blood pressure being a risk factor, prediabetes being a risk factor, diabetes being a risk factor. All of these things are heart disease being a risk factor. All of these things are also, they correlate with each other as well. What do you think causes high blood pressure? I think most of it's probably, we call it idiopathic, meaning we don't know. But I think a whole lot of it's very, very much related to clogging up our kidney filters and the kidney mechanism with AGE. And not age meaning old, but advanced glycation end products. We did a couple of videos on that a long time ago. Peggy Johnson, have you checked out the mushrooms like chaga? I have not checked out mushrooms. I mentioned reishi, Richard Lund did, and got it auto-corrected to relishing mushrooms. Stress reduction lowers cortisol, which was seen in COVID-2. Warren Crow, heard CDC rep and Trump COVID team speak of Quest participating in PCR tests. Your relationship, not an avenue to facilitating. Oh gosh, I tell you what, we've gone down a whole lot of pain on this PCR test. And yes, we do tend to use the Quest labs. Let me just make a simple statement on that. we were getting involved in setting up COVID-19 PCR testing for Kentucky, and that blew up. I'm not going to go any deeper in terms of what was going on. I will say that that was not really a Quest type of activity. Stress reduction does help. Amazon, been dealing with Life Extension Foundation for over 35 years. Extremely happy with their supplements, magazine, and database. I started vitamins in 1943. I'm happy with Life Extension as well. I think they've provided good information and good quality supplements. Karsten, again, low carb may be dangerous for COVID-19 as burns aerobic versus carbs burning anaerobic. And when the heart needs to work, die is close, maybe. Jan H., what adverse reaction might gut microflora give you with high levels of turmeric, curcumin, etc.? I haven't seen a whole lot of gut microflora issues with that. I'll tell you where you see gut microflora issues. You see it with antibiotics, for sure. You also see it with people with prediabetes. The gut microflora in people with prediabetes is very, very different from people that don't have it. And they've actually even done experiments where they did fecal transplants. This was in lab animals, and clearly the post-fecal transplant, the person started developing. I mean, the lab animals started actually developing prediabetes when the donor was a prediabetic. So that's a big issue. And they've characterized it as well in terms of certain types of certain species of bacteria and breadth versus narrowness of the colonies. So it's a very interesting topic. Overweight compressed on the lungs decrease their capacity for oxygen, and pregnant ladies late in pregnancy die. Ron Clark, my wife aged, I will tell you this, you do see that with several of the seasonal flu species. I think that's one of the things that's been characteristically different for coronavirus. SARS-CoV-2 has not been as lethal, as bad and as hard on pregnant women as some of the flu. Not all the flu, but some of the seasonal flus. Ron Clark, my wife, age 65, is scared to death of this pandemic. Won't leave the property for about a month now. I'm not scared of the pandemic, but I'm not leaving my property because it's just, to me, the smart thing to do. I'm having plenty of fun right here. I'm interacting with several hundred people, 93 of them right now. At Rob, as always, thank you for what you do. We all, faithful followers, listeners, appreciate you very much. Thank you so much, at Rob. I appreciate that comment. Rock you, please research Bill Gates' unhealthy conflicts of interest in the WHO and the other global vaccine programs he's invested in. If you're aware, please speak of those. I'm not aware, and I know that Bill Gates has had a lot of influence on these programs. No comment. Jackie Shaheen, can't help but to think people on TNF blockers like Enbrel are a high risk for strong COVID reaction. It's out of my pay grade, out of my expertise, Jackie, but again, anything that's impacting the immune system, you have to worry about. We've had a great response. I thought we've been trying to get this squeezed into about like half an hour. But again, so many good responses and so much good interest. I really appreciate it. And I appreciate the acknowledgement that we've been getting out there. Come take a look. If here's the thing. We used to think that it was, if you read Jenny Ruhl's book, RUHL, Blood Sugar 101. It's a book that's sort of a summary of her award-winning website, Blood Sugar 101. If you read that book, you'll see that she makes a really good case that at least half of us, by the time we're age 60, have insulin resistance or prediabetes. But you know what? Since that book was written, some very interesting information has come out. For example, a study out of UCLA showing that it's not by the time we're age 60, it's by the time we're age 30. Half of us have prediabetes. And if prediabetes is a major risk factor for COVID-19, if you get SARS-CoV-2 infection, what do you think that means in terms of our risk as a population? And what do you think that means in terms of you? Are you feeling lucky? Are you feeling like, I don't have that problem? Unfortunately, 90% of the people that have this problem that creates increased risk for COVID-19, prediabetes, don't think they have it. So that, to me, is the biggest problem. Thank you again for your interest, and we'll talk to you soon.